the the stuff that we talk about with airway here in this chapter is also going to relate to some of your skills that you'll be doing with oxygen administration, suctioning, that sort of thing, which are all things that if you're, CPR, first aid, that sort of stuff, you're not going to be able to do those things, per se. So there are several things that we'll talk about that are just do's and don'ts, little tips and tricks with O2 administration and suctioning and all that. It is, O2 in and of itself is a drug. So it's listed like that on drug cards for paramedics and everything else. It is a drug. It's a therapeutic drug. So it can do a lot for your patients besides just oxygenate the blood. Okay, there's a lot of anti-anxiety prospects to oxygen. Just putting the mask on somebody can and telling them that they're breathing oxygen can take some of that away, or it can give them anxiety. So it really just kind of depends on the patient. However, in most cases, it's really good at kind of taking away a little bit of anxiety and helping them to, settle down and breathe a little bit easier, both internally and externally. So airway management, again, we're going to talk about airway anatomy, airway assessment. So just assessing the airway in general. We don't know what's happened and we want to see what's going on with the airway. And then techniques for ensuring a patent airway, patent, however you want to say it. But a patent airway is essentially a clear air, an airway that is open and clear, so air can move in and out. So respiration is the anatomy of the respiratory system, physiology and pathophysiology of respiration, essentially how we breathe, how we exchange air, the pulmonary ventilation, which we touched on a little bit on Tuesday. So some of the things we talk about, transferring oxygen in the lungs and replacing oxygen with carbon dioxide. So oxygenation, we'll talk more about that. Respiration, external, internal, and at the cellular level. Talk about some of the assessment and management of adequate and inadequate respiration. So we'll kind of talk about what that looks like. What is adequate breathing? I see them breathing, but and what rate and quality is that breathing going to be good enough? Artificial ventilation, so, and of course, oxygen therapy. Artificial ventilation, so actually providing breaths. We're going to talk a few different ways of doing that. So minute ventilation, alveolar ventilation. We'll talk about the effect of artificial ventilation on cardiac output, so how that helps the circulatory system to better oxygenate the body as a whole. Pathophysiology, just simple knowledge about shock and respiratory compromise to respond to life threats. Again, all their stuff is connected. We talked about this the other day. Everything that the body does is all connected. So all these systems play a part on each other, right? So we have to make sure that we understand how those things help each other, so that we can better use the right methods and treat our patient the best way possible. So again, some of the most important life-saving skills, like I told you before, is airway care and rescue breathing. And those kind of fall into those ABCs that you've heard about in CPR forever, is airway, breathing, and circulation, right? And again, especially at the first responder level, the EMR level, we're not going to dive too awful deep into it, okay? Really just try to keep it simple whenever you're reading over your book, and whenever we get into skills and things of that nature, we're not gonna get so deep in the weeds that you get all confused, about cellular metabolism and how much sugar is this and that and acidosis of the lung. We're not getting into all that. All right. It's just not something that you need to be concerned with. So again, try to keep it simplified in your mind when you're reading this stuff. It really is very, pretty simple, ways of doing things. Even at a higher level, a lot of times that stuff doesn't come into play. A lot of that higher end stuff doesn't come into play unless you have a really, really sick patient. And, a lot of it is very simple, basic techniques and understanding of anatomy and physiology. And we're not going to get too deep in the weeds, like I said before, on a lot of this stuff in most cases. So again, we need food, water, and oxygen to live, right? So lack of oxygen, even for a few minutes, result in irreversible damage and death. That damage is caused by the lack of oxygen, all right, which flows to the blood, to the brain, and other organs. And so after a few minutes, you start to have irreversible brain death, brain tissue death, brain cellular death, right? And so that starts to control all those other things. Like we mentioned before, we talked about the spine Tuesday. And so a lot of those things are all connected, right? So if the brain's not telling the nerves what to do, then you're not going to breathe. Okay. And so that's a big deal. The main purpose of the respiratory system is to provide oxygen to remove carbon dioxide from the red blood cells, right? So again, a very similar, pretty much the same thing we saw Tuesday, just a general overview of the respiratory system there. Like we talked about, we have the upper airway, lower airway here, and the upper airway, the nasopharynx is the nose, okay, nasal passages. Excuse me. And back into where basically the top or the bottom of that starts is the oropharynx, so the oral pharynx, right? So the mouth, and that's where when we breathe in air, we open our mouth and we breathe and exhale air out of our mouth. That's how we're doing that, and those passages come together right there around the pharynx. So the pharynx going on down there is just that intermediate area between your epiglottis and your oropharynx. Okay, so the epiglottis, it's kind of hard to see. If you zoom in a little bit, you can see it's kind of like a little flap there. It's kind of this cutaway version. It's hard to tell, but it's essentially a little flap of tissue that is essentially a flapper valve. Okay, and that flapper valve lays over on top of the trachea while you're swallowing to prevent food and liquids and things like that coming down into your trachea. Okay, and it kind of funnels it down into your esophagus, right? So where it goes to your stomach. Occasionally we get things that sit on top of the epiglottis, and then we have issues where the epiglottis can't open. Okay, so now we can't get air in or out, and obviously that would be choking, right? It'd be a form of choking. So we could block the airway. You could block the airway at several different locations, but that's a primary one where you get food or water sitting on top of the epiglottis. And you ever heard the saying, "Oh, it went down the wrong pipe," right? So you drank some water too fast, or you're bent over when you drank the water or something, and it goes down the wrong pipe. Well, that's what we're talking about. It's where that water is sitting on top of the epiglottis and it's trying to go down the trachea, but your body's fighting really hard not to let that happen, and so it keeps that epiglottis closes. Hence, you start coughing and choking. Okay, so going on down there, we talked about the different sections of the lung Tuesday. We're going to get deeper down into the bronchioles and alveoli. Excuse me, here in just a little bit. So in an unconscious patient lying on his or her back, the passage of air through both the nose and mouth may be blocked by the tongue. So we've had this happen over the years to like dentist offices and doctor's offices and things like that, where they're receiving some type of local anesthesia or laughing gas or some type of issue where they're getting knocked out, and their chin is their chin is to their chest, and they just, they passed out. And so they call 911. We get there, and we literally do a head tilt chin lift, lay their head back a little bit, and open their airway, and voila, they start breathing. So, that's just a very simple example, but that's realistically as easy as it is for somebody who's at rest like that. Their tongue can fall back. If they're really relaxed, their tongue can fall back in their throat and cause that blockage to occur. Just everybody has different size tongues and everything else, right? Different size oral pharynxes and things of that nature. So it's very conceivable and happens every so often where that will happen. So a partially blocked airway often produces a snoring sound, right? So for those of you who snore a lot or wake yourself up from snoring, it's not the sound that's waking you up from your snoring. It's the partially blocked airway that your body tells you, oh, by the way, you stopped breathing for a few moments and you need to wake up and fix that. All right, that's your brain's way of doing that. So again, just, as another general view here, you have the tongue occluding the upper airway where it falls all the way to the back and doesn't let the air go down. And then if you head tilt chin lift, open the airway, pick up the back of the neck a little bit, and really rock that head back, you'll get that airway to open up and basically pull that lower jaw up and away from the back of the throat. So like we said, we have the esophagus and the trachea. Both, the trachea sits in front of the esophagus. So what you feel in the front there, if you press on the front of your throat, that's your trachea, okay? So we talked about the epiglottis. The airway divides into bronchi as it goes down at the carina, and it splits off there. The lungs are located on either side of the heart. So, for those of you who think that the heart is completely on the left side of your chest, you'd be wrong. It's actually more in the center of your chest at a slight angle. So the smaller airways that branch off from the bronchi are called bronchioles. So you have bronchi, then bronchioles. And the bronchioles end as tiny air sacs called alveoli, right? And we're going to break that down here in a second. The exchange of oxygen and carbon dioxide that occurs there at the alveolar ventilation. All right, so here's what we're talking about. So you see the bronchiole up there at the top, right? That's one of the stems coming off of it. And then as it comes down, you have all those different vessels, like we mentioned Tuesday about those vessels that are all intertwined with the alveoli. And that's you have those vessels are oxygenated and deoxygenated blood, okay, or vessels. So they have one of them is taking good blood to it, and the other one is filtering out and returning that bad or that deoxygenated blood back out. So as you can see there, number one, deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and arterioles. Okay, so we mentioned that Tuesday also. We talked a little bit about the flow of the heart, and as the heart pumps that blood into the heart, and then it pumps it right back out just to the lungs. Okay, comes to the lungs. Now here it wants to get oxygenated, so it's just half of the pumping process, right? It pumps it, pushes it to the lungs, pushes it down into the alveoli. As you breathe, every time you breathe, that's oxygenating that blood. All right, so that oxygen that you breathe in is then oxygenating the blood. Okay, so it's coming down the blue tubes here in this picture. It gets oxygenated, goes back out the red tubes as oxygenated blood back to the heart, and then it gets pushed out on the left side of the heart to the rest of the body systemically. Brain, lungs, brain, the big toe, little finger, and everything. Okay, so Again, like it says there, gas exchange takes place. Number 3 is that oxygenated blood is carried to the heart by the pulmonary veins and venules. So, again, we're not going to get super deep into it. That's essentially the basics of how that happens. There's a lot more. We can break this down a lot more at the vascular level. However, it's just, that's just the main things that you have to understand is that when the lungs have fluid on them, when the lungs are damaged, right? So you have a stab wound, gunshot wound, a piece of flying debris from a hurricane stuck in somebody's chest or whatever, and in their lung, it's damaged some of this process, and so we need that process. Now, if for some reason they aspirate stuff and they get fluid in their lungs, they near drowning or drowning, all those different types of things, or even some type of fluid that our body makes because of we have something fluid backing up in our system, and it fills up the lungs partially. Well, that's gonna make that process of gas exchange even harder, right? It'll be like being underwater and trying to, if you think about trying to breathe underwater, you just can't do it, right? So it's the same concept. We have water down in there, it's just we're not gonna be able to exchange that gas like that. So again, one of the things to remember when we're listening to people speak and we're assessing people's breathing, that sort of thing, if you think a little bit past that, and you can hear them, it sounds like they have wet breath sounds, and we'll get more into breath sounds later, but their speech almost has like a wet raspiness to it or something like that. Those are indications. That's an auditory indication that, hey, they may have some fluid in their lungs. All right. And if we hear that through a stethoscope, we can also hear that and say, hey, they definitely have some kind of liquid fluid in their lungs. Don't know how much, right? Other ways we can look and see about fluid backup, but there is definitely, you can equate that to what's going on in this alveoli, is that the gas exchange is not there, which is essentially is going to start to cause systemic problems. Things are not going to get oxygenated as well, right? So it may not necessarily be the brain. However, it could be several other things in the body that are starting to not get good quality blood flow. Questions on that? All right. So again, it consists of the lungs consist of soft, spongy tissue with no muscles. Movement of the air into the lungs depends on movement of the rib cage and the diaphragm. Okay, so when the diaphragm contracts during inhalation, it actually flattens out, okay, and moves downward. So it allows for that contraction of the lung, okay, the lung to inflate. On exhalation, when you breathe out, the diaphragm relaxes and once again becomes dome shaped, kind of like it is when it's at rest, basically. So as you even those little breaths that you take, just like I am right now, I'm speaking, all right? So I'm not taking big, deep breaths, but during that normal speech, it's every so often it takes small little lifts of that diaphragm to open and close my lungs. So you don't feel it. It's not, it's obviously not something that you notice. You take, a lot of breaths every day, right? But you're not going to realize that. However, when you have somebody a sick patient who is having some type of breathing difficulty, and maybe a habitual smoker, somebody who's having some other, chronic breathing issues, COPD, emphysema, things like that, you'll be able to see that laboredness of that whole motion go into effect. And again, we're going to get more into that when we get into some of these other issues. But that's just one of some things that you, knowing how this normalcy should be of the body, then you can, whenever it's sick, you'll be able to really look at it and go, oh, that's going to smack you in the face and go, hey, that's not right. All right, so just a little representation there. Like I said, when you inhale, it'll contract and flatten out, and when you exhale, the diaphragm relaxes and kind of forms a little bit of a dome or a inverted C. So we mentioned ABCs, right? So A is for airway. So airway is different than breathing. All right, airway is that the structure, the way, the area in which we have to move the air. Okay, and then breathing is how we actually make that happen. Okay, so the airway again is is all the structures that we had mentioned before: nasopharynx, oropharynx, those types of things, trachea. And so we want to make sure that all these things are in the right order so that we can breathe appropriately. All right. If our airway is obstructed, then our breathing is going to be affected, right? So normally it stays open for injured or seriously ill patients. It's not able to protect the airway and it may become blocked. So it's our job to help correct that problem. Again, it sounds silly. We talk about this during CPR. It sounds silly to do, but you have to verify. We're constantly verifying whether something is the way it should be, right? So if we can't ask the question, or the patient can't answer our questions, then we need to try and verify. So one of the ways we do that is just say, "Hey, are you okay? Can you hear me?" Okay, that's one of those little things that we can do to say to alleviate or to assess multiple things. So if I say, "Hey, are you okay? Can you hear me?" and the patient rolls over, looks at me, and says, "Yeah, I'm okay, but I think I was choking." All right, that tells me that they have a pulse, they have an open patent airway. All right, and that they have the mental capacity to answer questions. Okay, so I have done a lot of things with just that, with just those two questions, right? So when we talk about bedside manner and patient assessment and all that sort of stuff, think about it in that context, right? You know, if you can answer a ton of questions and get way down that checklist with just a few short questions, you're doing really good. Okay. But you always have to be you're constantly thinking about, is that answered appropriately? Is that question good enough? Or is that answer to my question good enough for me to go on to the next one? All right. Or do I need to dig a little bit? So if you get a response, again, assume the patient is conscious and has an open airway. If there's no response, gently shake the patient's shoulder and repeat your question. And that's just one of those things, too, where we start to get into level of consciousness. And again, it's another thing we'll talk more about. But the level of consciousness is, are they kind of awake? Or are they all the way awake? Or, they're completely unconscious? And the level of consciousness allows us to, again, goes right back to what we were talking about Tuesday with liability, right? Or consent is, if they're unconscious, am I using implied consent? Or, if they're conscious, but if they're semi-conscious and they're not able to answer your questions appropriately, again, same thing. We may have to go with implied consent. So it's just one of those things that you're constantly checking a box, when you're doing stuff like this. So we're looking at legal stuff. We're answering medical questions. We're answering, neurologic questions and all these other things by just asking them a few short questions like that. Okay. So again, checking for responsiveness, shake and shout. They don't respond, call 911 first before doing anything. Well, we are 911. So that would be a good indicator for us to maybe say, if we have an unconscious patient, to let our dispatch know, let the higher level of care know that, our patient is unconscious, they're unresponsive. and then we'll start working on other things from there. But that just lets them know that again, telling a paramedic that your patient is unconscious, that's not a common thing, right? So an unconscious patient is not good. There's a lot of different reasons why, right? And we're going to try to figure that out, but that's a big thing to know, right? That gives them a starting point. They don't have somebody they can talk to. So now they're having to start going down the rabbit hole in several different directions, trying to figure out what's going on with them. But nonetheless, again, our big thing that we're concerned with is airway, breathing, and circulation. That's the main things, especially from the EMR level, that we are worried about. We're worried about if the big three are there, hey man, we're doing really good. We had a bad call the other day, had a bad wreck the other day. I think there might have been a couple of you guys that were on it, and they had, person was bleeding from the head. Had a lot of bleeding in the vehicle. It was a rollover wreck, and patient was bleeding, and they were like, "Oh yeah, they're bad off," And I said, "Well, let's step back and think about it. Were they talking? Yeah, okay, they're talking, so they have a patent open airway, and they have some type of, they have a general mental capacity to somewhat have a conversation." Right, they were in a lot of pain, and so they're doing a lot of grunting and moaning and everything else, which again also lets us know that their nervous system is working, and that they're feeling pain. Again, it's unfortunate, but they had a really severely broken arm. Okay, again, unless it's bleeding out, not something that not something that's going to kill them in the next several minutes, right? So again, we talked about the airway. We know that they have a good that at the moment they have a heart rate, and they're alive enough to be able to talk to us, and it maintained that way for the duration of the call. So the duration of the call, they were verbal to some degree, again, in a lot of pain, but the airway was open. Bleeding was controlled, from the head injury. The head injury wasn't so bad that it was open, so answering those big three questions, the airway, breathing, and circulation, for us, that's, we're that's a win-win for us, at the basic level, EMR level, we're that's a really good day. Okay. If we have all that going on, the brain surgeon and the trauma surgeons and stuff, they can worry about fixing arms and repairing whatever, skull fractures and big stuff like that. That might be going on later, but for the most part, those are the things that we really need to have in order for those guys and girls up there at the hospital to really have a fighting chance, is that airway, breathing, and circulation. If we don't have that, we got much bigger problems. Okay. So again, talking about what your contribution is to the system, right? As an EMR, lowest level medically trained person. Okay, that's a huge freaking deal for you to be able to do that. For you to be able to make a that much impact on the patient's outcome by putting them on the helicopter, putting them in the back of the ambulance, getting them to the hospital with airway, breathing, and circulation. That's huge. All right. So, anything we do above that is cake. You know what I mean? That's lagniappe, right? So we want to make sure that we understand that you can do a whole lot of good with a little bit of effort, if you do it right. So moving on here, checking for responsiveness. It's really is. We talked about position the patients on their back and things. We don't want to have them sitting in a chair and all that sort of stuff. Sometimes if they're in a wreck, they're sitting up in a position, or some other type of accident. We want to have them in a position where we can at least try to adjust their airway or access their airway. If we can, they're not have some type of neck or back injury, we want to tilt their head back as far as we can. And this is for the adult patient, adult, or not babies. We definitely don't want to do that. And we're going to talk more about that next Tuesday when we get to CPR. But it's doing a head tilt chin lift and making sure that their head is in an inline position. Quickly scan the patient's chest for breathing and check for pulse. we mentioned this, we'll hear this again. We talk about CPR is, we give enough air to make the chest rise. All right. And so if the chest isn't rising, they're not breathing. It's a mechanical process. Okay. The chest has to go up and down for them to be breathing. All right. That diaphragm has to be moving. All right. In and out for them to be breathing. So we want to make sure that we do that. And we can look, listen, and feel, basically put your ear down to their mouth and listen and feel for breathing. And then look down their chest and see at that, and kind of get down there with that level and make sure that you see it going up and down. If it's not going up and down, that's it. That's all you need to know. If there's you give it less than 10 seconds, and if there's not breathing, then we need to start breathing for them. That's it. There is no other scientific method. There's no other machine that you need. Nothing. Okay. Do a quick scan, look, listen, and feel. No chest rise, no breathing. That's it. We're starting breaths. Okay. We'll get a rescue breath here in a second, but it's one breath every 3 to 5 seconds. And that's regardless if we have a pocket mask, if we're doing mouth to mouth, if we have a bag valve mask, any of these type of assisted ventilation type techniques that we're going to use, it doesn't matter. We're one breath every 3 to 5 seconds and ensure that the chest is rising and falling when we do that. So if the patient has a pulse but is not breathing, you need to correct the airway. So again, it's simple as that. We're doing a head tilt chin lift, we're opening the airway, or jaw thrust in our traumatic patients, and then we're going to start breathing somehow for them, right? So the head tilt chin lift maneuver is just what it implies. We take the chin, we lift it back, and we kind of tilt the head back a little bit. Now, I will tell you on like non neck and back injury patients, so patients that haven't fallen, been in a serious, car accident where their neck has been compromised or something like that, tilt their head all the way back. Okay. For the adult patient, you can tilt especially when they're unconscious, their head will go way back. Okay. Tilt their head way back and really get that airway open. And once you get it open, you kind of have to manage it. Okay. Because they're unconscious. I mean, their head's just going to roll to the side. It's going to slough back down. The chin's going to go back to their chest. Okay. Probably the easiest way for the unconscious patient is to put your knees on either side of their head. Position somebody at the head. And once you identify that they don't have, that they're not breathing, go ahead and put somebody at the head of the patient, put your knees on both sides of the patient and hold that airway in place while you do that. If not, you need to put something up underneath their neck, like a small towel or something. That way it'll kind of keep that tilt back. But once we do that, because once you start doing things with, again, masks and bag valve masks and intubation and all this other sort of stuff, the airway has a tendency to move back down. Okay. So it's in our best interest to try to maintain the airway. Okay. Maintain a patent airway whenever we do any type of opening technique. So head tilt chin lift or jaw thrust. So the jaw thrust, again, is for those we suspect have a neck or back injury. We just don't want to be moving their neck around, or we want to move their neck around as little as possible. So we try to use this technique whenever possible. But remember, this is life over limb for the most part. If we don't have X-ray vision, we can't see whether or not they have this injury to their neck, and they're not breathing. We need to do what we can to get those breaths in, right? So again, but we try to use the jaw thrust maneuver, and essentially, as you can see here in the picture, you go right up underneath the mandible, all right, where the hinge of the jaw, lower jaw is. Pick it up and take your thumbs. Your thumbs are kind of laying right there on their chin, and push their chin out or down. All right, so lift up and rock your thumbs forward. So if you're giving somebody the thumbs up, and then you point your thumbs at them. Okay, so if you think of it like that, so you take your fingers, wrap it up underneath the mandible, pick up, and then point your thumbs, at your buddy, right? So that's kind of how the technique would be, and that's the jaw thrust. So we're not tilting the head back; we're just lifting the jaw straight up and pushing the mouth open. Okay. So checking for fluids, foreign bodies, and dentures. The a lot of different things that people have in their mouth, whether it's stuff that they have in there, that again, dentures and all this other sort of stuff can be in there. That can be potential blocks for the airway. Again, with especially, it doesn't have to be traumatic. So you can have a lot of blood and all sorts of other stuff in your airway. Without ever having been hit by anything or anything like that. So there's a lot of different things that could be in there just from the body itself. If you find anything in there, we want to try to remove it. However, you need to be careful whenever you put in your finger in anybody's mouth. Okay, baby, child, adult, doesn't matter. Okay, you got to be careful with that. We used to use these bite sticks. It used to be in every medical bag you ever seen was a bite stick. It's not necessarily a bad thing to have. It's essentially like a little plastic wedge. And, sometimes dentists use it. We use something like that. But ultimately, if we're going to stick our finger in there and we're not sure if that patient is going to have a reflex or if they're going to wake up anytime soon, then we need to make sure that we are. So if they're talking about like overdoses and things like that, somebody who, we're not quite sure if they're going to wake back up or not, or especially if you gave them Narcan or something like that, and we're going to wake them back up, it's pretty good chance that when you start digging around their mouth, they're going to be reactive enough to close their mouth, okay, and then bite down on your finger inadvertently. So that's one of those things you have to be really cautious of. However, we want to try to get stuff out of there. So if they're unconscious, we roll them over and we'll try to remove whatever we can and get whatever that is out of there. For adults, sweeping in the mouth, just reaching in there, grabbing stuff, sweeping it out, not really too big of a deal. Just try to start from the back and rake your way forward. With infants and small children, it's not advised to do a blind finger sweep. You don't want to just stick your finger in there because your finger is way bigger than their airway. So it's you can actually push it farther back down in there. So if you see stuff in there, you shine a light or something, you see stuff in the airway, reach your pinky in there and you can usually kind of rake it out. Or if they're vomiting or something of that nature, we can kind of help it along. If and that way stuff doesn't just sit in their mouth, or if they have already vomited. So if the mouth is clear, consider using an airway device, and we'll get into those. So again, it just make sure that you do have a gloved hand. I would be cautious of again them vomiting. So just be mindful of that. If you want to wear glasses or goggles or something like that, that would probably be advisable while you're suctioning and digging around in people's airway. So moving on to suctioning, this is another skill that is a little bit more invasive. So we're actually sticking stuff into people's mouth, okay? And there's a lot of different types of suctioning devices out there. And this is a very rudimentary one. This is one I've had one exactly like this for a while. And it just allows you to get some of the basic stuff, mostly fluid. It doesn't do very well with solid stuff. So if you do have chunks of food or teeth or bone or whatever, it's not going to do very well for that. It's essentially a souped up turkey baster. Okay, it's not kidding at all. I mean, it's a turkey baster with a bag on it, right? So but that tube is a little bit wider. Opening, so it will get some more thicker secretions like mucus and blood. But again, this is just one of the manual suction devices. There's some out there that have like a hand pump on it, so it can kind of pull a little bit harder of a suction with that hand pump. Again, essentially works the same way as any other suction, minus the air that's attached to it. So this one, we just stick it down in there. We squeeze the bulb, stick it down into the airway as far as we need to, and then not to go all the way down the throat, but just in the airway, the back of the airway. And we will, as we come out, we are letting go of that bulb and let that suction grab a hold of whatever's in there, and then come out with it. Same thing. We push some air out of it before we put it back in the patient's mouth, kind of clear it out. Again, squeeze the bulb, put it back in there, okay, and repeat over and over until we can do that. However, we don't want to suction no longer than 15 seconds. 15 seconds, and that's for manual or powered or anything like that. As we're suctioning, we only suction for about 15 seconds, give them a few breaths, all right, and go back to it. So we don't want to deny them that oxygen if at all possible. Now, if we're not able to get those breaths in there because we need to suction, that's one thing. But if we can still get some breaths in there, get some air in there, let's try to do that. So again, we try to get out whatever we can with our gloved hand. We'll kind of reach in there. I'll show you guys a little technique called the scissor method. It's just a way of taking your thumb and your middle finger and opposing them like a little pair of scissors, and we'll open the teeth that way, and that helps us keep our whole finger from or help kind of open the teeth and keep them open. But once we do that, again, we want to try to roll them over when we do that and rake that stuff out of their mouth. And that way it just kind of gives us a little bit more room to suction, gives a little more visual line of sight. So this is a powered suction unit. This is something you would see on the ambulance. It has a big reservoir. That white top thing right there is just a big tub. There's a few different types of suction tips. So if you see what he's holding in his hand there is that long tube. That's a pretty standard yanker tip for the suction device. Right there where his thumb is a small hole. And so what's happening is when you turn that powered suction on, it is constantly pulling suction. All right. It's constantly wants to pull suction. But what happens is they make this small hole so that suction it's not creating suction right now until you block that hole. When you block that hole with your thumb, then it'll start the suction immediately. All right. So what happens is you take, just like we did with the other one, we're going to take it, put it down in the airway, and then we are going to block that hole. We're going to pull suction, and we're going to suction on the way out for no more than 15 seconds. Okay. Again, we'll get time to practice all this stuff. You'll see how it works. We'll set it all up, play with a few different types, but that's essentially the gist of it is no more than 15 seconds, and we suction on the way out. So again, maintaining that airway, again, for those unconscious patients, we try to continue to hold the head. Like I said, it's in the, we try to read it in the textbook and it sounds like it's easy or something, but it's not. There's a lot of stuff going on. And especially if it's just you, there's no way. You can't just hold the airway open. You have to reopen it all the time, every time you go to do something. So if you have more than one person, kind of dedicate them to the airway. It's that important, right? So dedicate them to the airway, tilt their head back, put something underneath their neck, put their knees on either side of their head, and hold their head in that position. That way, as you're, doing, suctioning, as you're doing back valve masks, as you're doing your pocket mask or whatever, you are, that your airway is open and in a position where you can do some good things. So we talked a little bit about the recovery position, the left or right lateral recumbent position. And we talked about that before with it being, again, if they're conscious, they regain consciousness to some degree or they're breathing on their own. We can try and roll them over into this position, essentially using that top leg as a kickstand, put that bent knee over onto the ground, take their top arm, take that hand and put it underneath their head, and essentially like they're laying in the bed sleeping on their side, right? And the other hand outstretched, and that again provides you two little kickstands, and you have a hand for them to rest their head on so they don't roll over. And if they do happen to vomit or or anything like that. It will just help to keep their airway clear so they don't aspirate or anything like that. It just makes it easier for them to breathe. And there you go. There's a picture of it again. All right, so airway adjuncts. Airway adjuncts. These are things that we can put into the airway, the oral and nasal airway, to help to keep the airway open. All right. So the oral airway, again, just maintains the airway, keeps the mouth open, and functions as a pathway for suctioning. If we need to, that way we don't have to keep doing that scissor method with our fingers and keep the airway, keep the mouth open, keep the airway open. We can just go directly down in the side of the mouth and do that. But ultimately, for us, for the unconscious patient not breathing, this is probably going to be one of our big go-tos. Is we call it the OPA for short, oral pharyngeal airway. The oral pharyngeal airway, or OPA for short. Okay, so the oral airway will go in pretty quickly. With somebody who's unconscious, not breathing, that's going to be one of those things where I'm going to make sure that they're really unconscious before I do that. I'm going to do my scissor method, and then we'll get into the actual mechanics of how to put it in there. But the other big thing is that they probably don't need to have a gag reflex. If they have a gag reflex, there's a potential for them not to be choking and gagging on it the whole time. So it may not be the best option for you. So this is an example of a couple different types. Again, these do the exact same thing. They just are designed a little bit differently. The ones with the hole in the center like that on the left are generally an older version. You don't really see very many of those being produced. A lot of the newer versions are like the ones on the right. So again, if for some reason they do have some vomitus, they do have some blood that creeps up into their airway just because of gravity or something like that, while we have this in there, there's the potential for that little space, that tube, basically essentially that center part of that J, to get clogged. Okay, so that's one of the drawbacks from that. But nonetheless, it does kind of keep the air open, keep the airway open, and ultimately what we're doing is, if you take the tip down there, all right, or which is the top, and so the top part here, which is the T, where it flares out, that's actually going to go be sitting on top of their teeth. Okay, and what happens is we take that curved part and we put it on the roof of the mouth, and then we rotate it in and down, and that goes on top of the tongue and then down into the back of the throat. And then that flared section sits on top of the teeth. And it's a really simple technique. It's really nothing to it. You'll get your chance to do a ton of it times on the mannequin, different mannequins, and you'll get it. It's not a big deal. And in some patients, you may just have to kind of finagle the tongue a little bit to make sure that it's not pushing the tongue back. But that's again, that just takes a little bit of practice to do that. But it's again, very simple technique, and just one of those things, one less thing you have to do with keeping the airway open. The other thing is they come in a lot of different sizes. So if you look, if you go and look at, for those of you on fire departments and also the sort of stuff, you ever look at the ambulance, you'll see that they come in usually like a little case, little plastic case, and there'll be little bitty baby ones, maybe inch and a half, big, and there'll be some that are, the extra large size that's, like 2.5, 3 inches big. So essentially what that does, what we do is we size them to the patient, and we size them by going from the tip of the earlobe to the corner of the mouth. So if we just take it and put it up to the patient real quick and put the flat part at the tip of the earlobe and then to the corner of the mouth with the curved end, you'll be able to see whether or not it's the right size or size that'll work. Okay. So that's as simple as it is to size it. Tip of the earlobe, corner of the mouth. Is it big enough or is it small enough? Yep, good to go. All right. Tip up, put it in there on the roof of the mouth, push it in and turn it. It's really not that difficult. So moving on to the airway, the nasal airway, or the nasopharyngeal airway, or the MPA for short. Nasopharyngeal airway. Pretty much the same kind of thought process here. We're going to put this down into the nasal cavity. Those of you who've had a COVID test, it's probably something similar to that. I would imagine it's going to go that deep down in there. But we're not going to go straight in with it. We're going to kind of go down and back, or back and down. But it's it's just a tube, right? It's a little rubber tube, and a few things we have to do with this versus the oral airway is that we've got to make sure that our patient doesn't have any head injuries or basal skull fractures or anything like that, where we might be impeding that. If their head injury is to the back or something, that might probably be fine. But with any of these basal skull fractures in the front of the face, or facial fractures that are very serious, it's contraindicated to use the nasopharyngeal airway. So it's not nearly as likely to cause vomiting. You can suction through a nasal airway also. You can run a tube down there and suction through that. If for some reason the mouth is all mangled and traumatized, you can also suction through that as well. Provide you a little bit smoother path for that. So same thing. The tip of the earlobe to the patient's nose instead of the mouth. Okay. So for the nasopharyngeal airway, it's going to be the earlobe to the patient's tip of the nose, and that's how you know the size is correct. The other thing that we need to go along with this, and so if you have some of these, I would just take some of the individual packets of lubricant, water-soluble lubricant, and just tape it to it. Okay, so just run a little piece of tape around it, around your little, or if you have a box of them or something, make sure that you have some in there, and that way you make sure that you always have that lubricant with the airway. You don't have to worry about that. Again, everybody's got different things going on in their nose, right? So you got dry nose, you got wet nose, you got, snotty nose, you got, all sorts of different stuff. Okay. So, not trying to be gross, but that's just the way it is. Everybody's different. Everybody's got different nasal passage sizes, different things going on. So, the day that you decided to stop breathing is the day that you also had an inflamed, nasal passage from some type of, sickness or whatever. Okay. So that's just one of the things that we have to contend with maybe a smaller nasal passage because it's inflamed. So, by doing that, we want to try to look at the nose and see which one's bigger. So we kind of, just look underneath the nose and just see which, we call it each nair. So each nasal passage of your nose is called a nair. So look at the nair and see which one's bigger, and try to go with the bigger one. As you can see, these have a little bevel to them, like a needle. Okay, so they have a little bevel there to them. So what we want to do is take that bevel side of that tube and put it towards the septum of the nose, so the center section of the nose that separates the nose in two. We place that beveled part towards the center of the nair, and we're going to go in and down. So it's again not really that difficult. It does sometimes. Like I said, that's why we want to have that well lubricated, because sometimes it will kind of meet resistance. And as painful or as weird as it sounds, we need to try to push past that blockage. And sometimes it just takes us moving it up and down, lubricating that nair a little bit, and then working it down. It's one of those things that is, it just takes a little bit of practice doing it different ways. Even on the mannequin, sometimes it takes a little bit of, once we get it lubricated, it'll work. But again, making sure that bevel is towards the septum, and then push it in and rotate it down, and that trumpet part will essentially sit right on top of their nose, or right on top of their nair, and that's where it'll sit. So make sure you size it appropriately. Make sure that it's coated well, and make sure that it's inserted where that flange is all the way down against the patient's nostril. Okay. All right. So B for breathing. So we talked about airway. Now we're talking a little bit about the actual mechanics of breathing. So you can look, listen, and feel for breathing. That's what we were doing earlier. We're looking to see if that chest was rising and falling, right? See if there's any air moving around the mouth and in and out of the mouth. But our big thing, again, like we said before, is making sure that chest is rising and falling. The resting breathing rate for the adult is 12 to 20 breaths per minute. We saw Tuesday that little chart showed the adult, child, and infant, and the breathing rates, right? And respiratory rates, heart rates, and blood pressure. And again, 12 to 20 for an adult. We bump that up for children and bump it up even more for infants. So signs of inadequate breathing. Okay, we get there, we don't know what's going on. We get there for the breathing problem, having difficulty breathing. That's a pretty standard dispatch term, right? Patients having difficulty breathing. Okay, could be tons of things. So we get there, and they have noisy respirations, right? So when they breathe in, they have wheezing, they have gurgling, like we mentioned earlier. It just sounds wet. It sounds like somebody's trying to breathe through a straw. Okay. Those types of things, those are, again, auditory indications that, hey, something's not right. Okay. So make note of that. Once we kind of dive a little bit deeper into what wheezing is and all that, you'll kind of a little bit be able to better understand. If you want to, you can go out there. There's tons of videos on YouTube and things of that nature for breath sounds. So different types of breath sounds from actual patients that are, rales, rhonchi, wheezing, normal breaths in different age groups, and emphysema patients, and all these different types of, sick patients and their breathing and all that sort of stuff. So all that stuff is out there. That way you can kind of get a good feel for how those things sound. Rapid or gasping respiration. So rapid, again, obviously, if we're breathing too fast, then we're not getting as much oxygen in as we need to. And those gasping respirations, we refer to those as agonal respirations. Okay. So if they are agonal or gasping, essentially you may have an inhale and then really not even have an exhale. Okay. Or an exhale and you really don't even know that they inhale. And so it's just a big inhale and then they relax. An inhale and then they just relax. And it may be that those gasping respirations are every few seconds, every 10 seconds, stuff like that. That's not adequate. Okay. That's not going to get you your 12 to 20 breaths per minute. I can promise you. All right. So when you're faced with stuff like that, those are also automatic signs for you to go ahead and assist with ventilation. Okay. So whenever we have too rapid, where they're, especially when they're unconscious and they're just, I'm not talking about like I just ran a mile and I'm out of breath kind of rapid. I mean, this is so short, short and rapid that they're either they already passed out, so almost like a panting dog would be, and they're not able to control it. Okay. So whenever we have those gasping respirations or those very rapid, very gasping or very rapid respirations, we're going to want to start assisting ventilations at that point. Pale or blue skin. Okay. That goes back to how the oxygen in our body affects the other systems in our body. Okay. So that pale or blue skin is an indication, is a visual indication that our body is not getting enough oxygen. Okay. So the most critical sign is respiratory arrest, which is characterized by lack of chest movement, lack of breath sounds, lack of air against the side of your face. Okay, you look, listen, and feel, and you don't have any of that. Again, like I told you before, that's it. That's all you need. There is no other thing that you need to do, and you don't need to ask anybody else. You don't need to ask for advice. You do that, you do it appropriately, and you don't get those things. You don't get any of those things back. That's it. We're system ventilations. Okay. The other two are those ones at the top there, rapid or gasping respirations. Okay. So again, other signs, causes of respiratory arrest would be heart attacks. So, you know, the heart may have a blockage or something along those lines, and it's going to start to slowly affect how much oxygenated blood gets pumped back into the lungs. Okay, like we mentioned earlier, that gas exchange isn't happening very well because there's a mechanical problem with the heart, and it's not able to pump as much oxygenated blood. Okay. The mechanical blockage or obstruction, by the tongue, which we talked about earlier, so some type of, choking type situation. Vomitus, vomit in the airway, particularly in a patient weakened by a condition such as a stroke. So their nerves are affected. They're not able to effectively breathe on their own. And so it could be, again, some other type of foreign body in their airway, and their body's not allowing them to clear that foreign body out of the way. So talking about foreign objects, I mean, from kids putting Legos in their mouth and, not fully chewing up, even toddlers or, small kids who are ready to go back out and play with their friends, and they're eating a hot dog too fast or shoving a cookie in their mouth and running around, that sort of thing, to any number of crazy things that us as adults put in our mouth, to play a joke or to, have some kind of internet challenge or whatever. Okay. We've seen, you look at YouTube, you can see everything, that we, crazy humans, tend to put in our mouth. So illness or injury, again, we could have tons of those, that affect the airway itself. So any type of degenerative, diseases, trauma. So again, teeth and blood, and if you were trying to finish that Chinese food on your way home and then you got in a wreck, right? So, the windshield, you weren't wearing your seatbelt and you hit your throat on the steering wheel. You know what I'm saying? And so now you have facial trauma. You have crushed larynx. You have damage to the trachea, and then you have all this Chinese food stuck down in different aspects of that. You have it sitting on top of you have it sitting in all that crushed area. You have it sitting in the mouth. You have it sitting on top of the epiglottis. It's partially digested in the stomach, in the esophagus and down into the stomach. So if you think about stuff like that, what if that, that's a pretty bad case scenario, right? We have a lot of foreign body all throughout the airway, upper, lower, and then working its way towards the lower, and then in the esophagus as well. So that could be vomited back up. So now you have different types of different stages of food that's all in your airway. So very very dynamic situation for things like that. And you really have to focus on really getting that airway open as best you can. Again, it may not be possible. There's just some trauma that doesn't matter how much you suction, doesn't how much you open the airway or whatever. It's just not going to. Okay. The paramedic is going to have to, or paramedic or the flight nurse or somebody's going to have to come in and cut a hole in their throat. Okay. And we're going to get to stomas. That would be called a stoma, and we're going to get to that in a little bit. So again, some other respiratory arrest. Respiratory arrest, again, is that just ceasing of that respiratory drive. So the respiratory system just isn't outputting anymore. It's not working. So that's going to be, again, things like drug overdose, poisoning, severe loss of blood, electrocution. Any of these things can be potentials, can have the potential for to cause respiratory arrest. Typically, if you have respiratory arrest, which is again where you're not breathing at all, it doesn't take very long, and you're going to go into cardiac arrest. Okay, so it's very important. It's very quick. It's something we need to do very quickly, is to ensure that open airway, so that we can at least try to keep the circulatory system going, even if we have some type of respiratory issue. Okay. All right, let's take 10 minutes before we get into this other section here, and we'll come back. So 10 minutes from now, come on back.
Are y'all on a break?
Yeah, we're on a 10-minute break.
Logan is with me.
All right, let's get back to it. All right, so we covered several things here in the last last hour or so. What anybody got any questions on any of that stuff we covered? All right. So moving forward with the presence of breathing, we talked about a couple of different ways of checking breathing, right? The assessment of any motionless patient begins with checking for responsiveness. So we talked about that a little while ago, and we'll talk more about levels of consciousness later, but it's essentially we really need to understand what level they're at. And somebody who's unconscious with a little bit of coaxing and a little bit of what we refer to as painful stimulus can sometimes awaken them to a degree where they actually just start breathing again. We had one the other day that was an overdose, and it was, they were out. I mean, they were not breathing. Put a little bit of downward pressure with the knuckle of one hand, one finger, and in the center of the sternum, and in a round rotating motion. And generally, if they are at any degree conscious, they will respond to that. Okay. And no, I'm not being, I'm really not being mean or facetious here. That really is a method for us to be able to check for a level of responsiveness. Pain is a degree of responsiveness. So, not that we're trying to injure our patient or hurt our patient in any way, and we're only doing it to the level at which we can get some type of response, or that we generally get a response. So we're not, if we apply a little bit of sternal pressure like that, or pinch a baby's foot or something of that nature, we're not going to keep doing it until they and see if they wake up. We're going to do it enough to see if they respond to it. If they don't respond to it, then we understand that they are absolutely unconscious. Okay. However, if we don't do that and we just jump in there and just start doing stuff, we might be doing that on somebody who is semi-conscious. Okay. So checking for responsiveness, shake and shout, see if they're responsive. If the patient's unresponsive or unconscious, quickly scan the chest, like we said, to see if we see that chest rise and fall, right? So we talked about rescue breathing, and that rescue breathing essentially is just providing ventilations, is one breath every 3 to 5 seconds. Okay. It really it doesn't take very long whenever we're doing, this is talking about mouth to mouth breathing, but we're generally not going to do that, especially on the, definitely on the, not on the professional side of the house. I just wouldn't recommend doing that. I've only done that once, I believe. Yeah, once in my career, and that was on like a 3-month-old baby. So I really didn't have a problem doing that on a 3-month-old. I'm pretty sure they didn't have a whole lot of communicable diseases. So that was a chance and a risk that I took, for that patient's benefit. But just because I didn't have anything with me that was suited for an infant. But once we got in the ambulance, we started doing other things, but intubation and other types of size masks and all that. But nonetheless, want to make sure that regardless of what you're using, you're giving that breath over about 1 second. And again, we don't want to go so fast. We also want to let the patient's lungs deflate. So make the chest rise, let them deflate, give another breath, inflate, deflate, give another breath. Okay. If we go too fast with those breaths, we end up with we can end up with what we call gastric distension. We're going to cover that more in a second, but essentially pushing air into the stomach. So you heard me talk about pocket masks earlier. This is a version of a pocket mask. Yeah, this pocket mask kind of, it'll flatten down. That little dome part will kind of push, you can push it down into the mask, and the little mouthpiece there comes off. It's a great alternative to have if you're going to be a first responder EMR. I would definitely have one or two of these in your bag, and it's a good, like I said, it's a good option to be able to utilize, and it's again, very easy to use. So the little mouthpiece there is a one-way valve, so air can go in but not out, and that means that vomit and any other things that come up through there, spit or anything, can't come up and get in your mouth. So we'll talk about that when we do skills, but essentially when you're doing that, you can do it from the side. It's also recommended to do that with a head tilt chin lift and pull back on that chin. Put your oropharyngeal airway in, and then you can really keep the airway open while maintaining that head back and lay down in from behind the patient's head. And then outstretch your two arms, reach up there, grab it, push down on the mask, pull back on the chin, and then you can provide your breaths. So also referred to as a barrier device, anything that just gives you any type of barrier between the patient and yourself would be a barrier device. There's stuff out there for little piece of plastic. I have one in my bag right here. It's just a little bitty small keychain size. I mean, like, 1 inch by 1 inch, little Velcro back case, and inside of his little piece of plastic, and it has like a little mesh valve on it on there, and you just lay it over the patient's nose and mouth, pinch the nose, blow through the screen and the mesh screen there, and you give your breaths that away. So obviously field expedient stuff. You could use saran wrap. You could use a plastic bag, any type of plastic bag that chips come in, or bread, or a Ziploc bag. And if you get creative, you can use all sorts of stuff for a barrier device. So the bag valve mask, or the BVM, this is something for those of you that'll be in the fire service, law enforcement, around the ambulance, stuff like that. You're going to use quite often. This is something that we have. I mean, I have a couple of them. You can usually swipe one from the ambulance, ask real nice, and they'll give you one. But it's one of those things that just kind of it helps give the optimal amount of air for the patient. We're not having to do any guesswork. And so that's essentially what it looks like. Again, several different models out there that look a little bit different. Excuse me. All of them essentially will kind of push together. So it'll be if you take each end of that football looking device part there, that bag part, it will actually push, each end will push in to itself and reduce the profile of it, reduce the size of it, and then the mask detaches from it, and it'll have a tube coming out of the back that'll hook to the oxygen, so that we can provide 100% oxygen or as best we can to the patient as we're giving breaths. That's always a good thing. We're going to get more into O2 here in a little bit, but that's definitely something that we want to try to achieve whenever we're doing respirations. So the bag valve mask, again, holds about 800 milliliters of air, and that essentially is just proven to be what most adults will breathe in and out, just in general speak. I mean, there's a lot of different variables there, but essentially we still want to give the breaths over that 1 minute, that 1 second, over that 1 second, and we want to look for that chest rise. Okay. So having a partner hold the mask back and down and pull the head back, open the airway with an oropharyngeal airway in, gives you your best route for success when it comes to giving these respirations. Okay. Again, we're going to completely compress the bag with both hands, and we are going to see, we should see the chest rise. Okay. A lot of times when you're doing this for real and you're helping out the ambulance and you're on scene, it's going to be you doing it. It's not going to be a 2-person deal. There's just too many people are right there around the patient, and really need the basic from the ambulance, the paramedic, or the couple paramedics that might be there, or whatever's going on for them to be starting IVs and, starting to think about intubating. They're getting stuff ready. They're doing all sorts of different things. So they're kind of right there around the patient. And really there's only space for you at the head. Once you're in the ambulance, same thing. You're sitting back there on the jump seat, and if you're helping out, and there's really only space for you to sit on the jump seat, and you're kind of leaning forward, and the patient's head is right there, and you're having to consistently hold pressure down on the mask with one hand, the EC hand technique, and then pulling back on the head to keep it open. So it can be challenging. Your hands will get tired. The palms of your hands will cramp. Your hands and your gloves will get sweaty. Depending on what the patient's like, what the scene is like, you could have blood, body fluids, things like that all over the bag, all over the mask. So I mean, it really just depends. But you could have a lot of different variables there that make it kind of difficult. So just kind of have to work through it. Try to provide a good seal. If you need to wipe the patient's face with blood or body fluids, wipe their face with a towel real quick. Kind of, wipe the mask a little bit, and make sure you got a good seal, and you're not just up there, just blowing air out of the side of the mask, and the patient's not even getting any breaths. Okay. But again, if you have O2, want to try to hook O2 up to it, and at least 25 liters per minute, which again, we'll get more into oxygen than liters per minute in a minute. So airway and breathing review, like we said, the airway is the structure that allows the air to flow through the body, flow into the body, in and out of the body, excuse me. And so that was, that's one of those things that we want to make sure we check and make sure that they're responsive. If they're unresponsive, let somebody know that. So let EMS know, let dispatch know that, hey, this patient is absolutely unresponsive. Okay. Place the patient on their back, quickly scan the patient for signs of breathing. Like I said, want to look for that chest rise and fall, check for a pulse, carotid pulse, right there on the side of the neck, just down from the front of the neck down the side, and feel for, just a few seconds, and let's see if they have a pulse. If not, if they do have a pulse, that's great. But they may still be not breathing. Then we're going to do that head tilt, chin lift, or jaw thrust, and we're going to start to provide breaths. Okay. When we do that, check for anything in the mouth. Again, if it's an unknown type medical scenario, we get there and we're not sure what's going on, but they're not breathing, let's take a quick scan inside the mouth and see if we can see anything. But again, be very cautious about putting your fingers in their mouth. It doesn't mean that you don't look in there. It just means that you need to be cautious about how you do that. So if there is stuff blocking the airway, we may need to use suction, manual or mechanical suction, to remove any of that stuff that's in their airway. And then we're going to try to start to make sure we maintain that airway and hold it open. Again, oral pharyngeal or nasal pharyngeal airway, oral or nasal airway, to try to help us accomplish that. Breathing, again, is the actual mechanical part of getting that air in and out. And we check for presence of breathing while determining responsiveness. So like we said, look, listen, and feel for breathing. Check the lack of breathing by performing rescue breathing. Use a mouth to mask or mouth to barrier device if available. So that going back to the mask or the bag valve mask, BVM, one of those, is kind of our go-to in EMS. So rescue breathing for children, going forward, whenever we get to kid stuff, I'm going to reiterate this, and it's just, it's difficult for any level. Okay. Like I said, I've been doing this for a long time. I've seen what it does. I've seen what children do to people, to very skilled, educated, highly experienced medical providers. I've seen what it does to cops. I've seen what it does to their driving. I've seen what it does to their decision making. There are, I've seen a lot of very competent adults do a lot of crazy things to try and help a child, rescue a child, and things of that nature. And again, it's notable. You know what I mean? It's a noble type thing to do that. However, some of the things that I've seen over the years have been downright stupid and dangerous, very dangerous. I'm not just saying like, oh, they took a risk or whatever. No, I mean like they almost killed other people doing what they did. So you have to, when it comes to dealing with kids, especially really sick or injured children, you really have to take a second, take a breath, get that out of your head, and just treat the patient. Okay, whether they're 6 months or 60 years old, it doesn't matter. Okay, that patient is the same as the other patient. Okay, so that's one of those things that, yes, we were going to get in a hurry. Yes, we're going to make sure that we, we're going to get there quickly and make sure that we do everything that we can to help that child, no doubt, right? But like we talked about in that ethics class the other night, it's important for us to treat every patient the same. Okay, we give that same regard, we give that same level of care to the elderly patient or the 40-year-old patient as we do the 6-month-old or the 16-year-old. Okay. So again, take a second, take a breath, and focus on what you need to do. There are differences if you've learned in CPR. If not, you'll learn Tuesday. There is certain things that we need to do differently for children than we do for adults, and especially infants. So because they're infants, their airway is is obviously smaller, and they kind of tilt their head a little bit more often. You don't need as much to open their airway, and so we don't want to do that full big old head tilt chin lift like we talked about on the adult patient. Really, we want to put those, especially infants, in like a sniffing position or just like we'll call it a neutral position, and have their head in an inline position like that. That's going to give us enough to do what we need to do. The breaths per second is the same though. One breath every 3 to 5 seconds, about 12 to 20 breaths per minute. And, because especially with child and infants, that mask that we use may not fit them. Okay. It may fit across their whole face, right? It's not just their nose and mouth. So one of the tricks for children, not infants, but children, is to take that mask, take the pointy end and flip it around and put the rounded end on top and the pointy end on the bottom. That's a quick little fix. It depends on the child's size, but that's one little things you can try to see if that'll make a better seal with the mask. If not, you're gonna have to get you a smaller mask, okay? Or else you're really just kind of blowing air out the side and it's not gonna be doing anything. So again, we have to try to treat them gently. We can't hold their head down, like that. We can't put we can't put our body weight on their head and hold their head down and all that stuff. All right. We really need to, again, put their nose basically up, like almost like they're looking up at something, and not quite so, and don't tilt their head so far back. Their head is for infants, their skull is not completely fused together yet. And we need to, and they have a little soft spot on the top of their head called a fontanelle. That fontanelle is, susceptible to injury. So we don't want to be putting our fingers on there. We don't be pressing down on the skull too much or anything like that. So that's another reason why I tell you to slow down, calm down before you start dealing with these delicate little babies. You will hurt them because you are so anxious and amped up. Okay. Or you won't hold them well enough because you're afraid that you're going to hurt them. So people will just kind of gingerly hold them. You need to, secure them, hold them firmly, But in the areas of the head and the neck and things like that, and the chest, you have to be careful about how hard you're pressing on them. So the tongue, like I said before, is a common one for airway obstruction. For children and infants, it's going to be those foreign bodies that they put in their airway. The Lego, the hot dog, the cookie, whatever. And that's one of those that you just have to play by ear depending on what it is. So again, these are just 4 types there. Tongue blocking the airway, injury, so trauma to the throat, like we talked about the steering wheel hitting the trachea. Swelling is another one, and foreign objects. For those of you that are firefighters in the room, swelling is a potential for us. If you, for some reason, get superheated gas in your airway, or you have a burn patient. You have a burn patient from a house fire or structure fire or something like that. It doesn't have to be a structure fire. It could be any type of fire that breathed in superheated gas, and it causes swelling of the airway, of the upper or lower airway. Then you have the potential for that airway to close, okay, or severely reduced airflow. All right, so that's one of those things that they really need to get them intubated quickly. A lot of times the patient may still be very conscious, but the swelling is going to soon take over, and the advanced paramedic on the helicopter and the flight nurse are going to have to, what they call RSI, or rapid sequence intubation. They're going to have to basically paralyze the patient, and then they're going to have to sedate them, and then then they'll be able to intubate them chemically or by using certain types of drugs. So that's one of the things that is a dynamic situation with that. But again, one of those things to be considering in those types of events, if you do have patients that are around that have been involved in some type of fire-related issue, a lot of times whenever a flash of fire happens, you have an inspiratory gasp. So when people go, all of a sudden, you may not hear it like that, you may not realize it, but they take a big deep breath in, and that's their body's natural reaction to go, I need oxygen because I'm about to haul butt out of here. Okay, that's literally what your body is doing, because the brain has told it, hey, something bad is about to happen in like 2 milliseconds, and you need to react to it. You need to get away, jump high, start swinging, whatever. Okay, fight or flight, and you got to do something about it. And so the brain's like, hey, before you do that, I'm gonna need some oxygen to make sure we can make all this stuff happen. Okay, so you take a big, deep inspiratory breath, and that's typically how you end up with those, what we call inspiratory burns. With inspiratory burns, you typically will have stridor. Stridor is that obstructive airway sound, and again, it's almost sounds like wheezing, but not quite as high pitch. So. All right, so we went through this stuff earlier. Mild airway obstruction, if patients are coughing, gagging, but they still can speak a little bit, the biggest thing is to let them keep coughing. Let them keep coughing, maybe a little drink of water, not much. Maybe it depends on what it is, if it'll soften it up or lubricate it a little bit. Sometimes a little cola or, root beer, some type of carbonated beverage will break it down a little, whatever it might be, break it down. But if it's a child with, a Lego or whatever, it's not going to really do much. So, we really just want to kind of let them continue to cough it up, and hopefully that it'll start to move around on its own. Big thing is have them relax. Try to relax. Don't freak out, because the more they tense up, the more the muscles and the structure of the throat tends to tense up. Okay, so it doesn't make it any easier for them to pass that obstruction. So severe airway obstruction, again, the patient is unable to breathe in or out. Speech is impossible. I mean, that's it. It's done. Again, if there's any cough, it's very mild, and loss of consciousness is coming in just a few minutes. Okay. So if you're there, they're choking on something, they're coughing or whatever, then all of a sudden they stop, they look you dead in the face, and they start panicking. Okay. And they're not able to do anything. They're not able to talk and all that. You can bet that it's going to be like a chicken with their head cut off. They're probably going to start moving around. They're probably going to start grabbing on people, grabbing on you, things of that nature. And they're going to get very panicked. And whatever, because they do that, because they panic, the oxygen in their body is going to be used up faster. And they're going to be out real shortly. Okay, they're going to go unconscious. So, if they do that, essentially we're going to try to do chest thrust. It says abdominal thrust. Excuse me. But for AHA guidelines, American Heart Association guidelines, we're gonna use chest thrust. So essentially chest compressions, CPR, and because like we said, if they're not breathing right now, it doesn't take very long for that to convert into cardiac arrest. So the motion of us doing chest compressions will do very similar to what abdominal thrust would do, and also try to push air up and through from the underside of the obstruction and help to get it out. Kind of helps move it around as we're doing compressions, but also it moves that oxygen back and forth. Moves that blood back and forth to help keep that blood flow going in the event that their heart stops. So, we have the airway obstruction. We haven't talked about it yet, but is basically the Heimlich maneuver so that would be for the conscious patient. So the conscious choking patient, it needs to be something where they are absolutely choking. If they are just still talking to you and that sort of thing, we're not going to necessarily do the Heimlich maneuver. So I can tell you, I have had to have the Heimlich maneuver done to me. I'm not necessarily ashamed of it. It's an accident. It was something that I didn't see coming. It was my own fault. I should have chewed my food more. And this is as an adult. It's one of those things that it's very scary. You're chewing your food, you're talking, you're taking a few sips of drink, and then you're going back to talking, and whatever. And then all of a sudden it locks up just like that. Okay. So when you're doing this, you need to make sure, for one, that you're communicating with your patient. Okay. If you're a bystander, especially, so if you're not in uniform and you're not there, officially to respond to the call, and you just so happen to be in the same restaurant as somebody who's choking, you especially need to look them in the face, ask them, are you choking? Can you breathe? And if they can speak to you, right, we're starting to answer some of these questions that we had earlier. How much of an obstruction is there? Well, if they're still talking to you and they're coughing a little bit, it's not fully blocked, right? So that's a good thing. We've learned a lot by doing that, by asking that question. The other thing is, if they're not choking at all and they're playing some joke, they're messing around, whatever, and we just come up behind them, don't say anything, grab them around the waist, and we just start, pulling on their stomach, and they start yelling, "What are you doing? Why are you, I mean, you're going to get yourself into potential civil liability at that point. And depending on the person these days, you could face criminal charges for doing that, regardless of whether it was an accident or not, whether you thought that said that they were choking, or that they looked like they were choking or something like that. You're going to, you open yourself up, right? So you just grabbed a complete stranger around the waist and said nothing to them, told them nothing, and started pulling on their stomach. Okay. So, if they are choking, ask them real quick. Again, take just a second. Hey, are you choking? And they start nodding their head and looking at you, big wide eyes, and they're choking. Hey, tell them, okay, hey, I'm an EMR. I'm here to help you. I'm going to be doing the Heimlich maneuver. Turn around for me, and try to relax. And then we'll start doing the Heimlich maneuver. We'll get in the Heimlich maneuver more when we talk about CPR on Tuesday, but there are, essentially we're gonna pull inward and upward on the stomach and try to force some of that air, try to force that diaphragm up to assist us with getting that obstruction up into the upper airway instead of down in the lower airway like that. So it's that's for the conscious choking patient. Again, once they go unconscious, like we just said, we lower them to the ground and we look in the mouth and see if there's anything in there, and we start going into CPR. Okay, so for the if we have suction, that we can attempt that and see if that helps. But if it doesn't, then we're going to just continue with our CPR. Not much different for a child. We just kind of have to maybe take a knee and do our Heimlich maneuver. And if they go unconscious, again, same thing. We're doing CPR. The airway for the infant is a good bit different. We're going to do back blows and chest thrusts. So for our infant, we're going to lay them down in our hand, hold their face with our hand, and put their body over across our arm, lower their head down, give 5 we call back blows. It's essentially just taking your palm of your hand and hitting right between the shoulder blades with the, just not super hard, okay? So we don't want to injure them, but just enough to kind of cause some vibration in that downward motion, down and away. We don't want to hit them in the back of the head. And then we do that 5 times, flip them over. We do 5 chest thrusts, same exact way we do CPR, right in the center of the sternum, and called the intermammary line between the nipples, 2 fingers, and we give those 5 chest thrusts, 5 back blows, 5 chest thrusts, 5 back blows. We do that until the object comes out and they start breathing, or they go unconscious. When they go unconscious, same thing. We start CPR. Okay. The only difference is with any of these is once we do CPR, we do our chest compressions. Before we give our breaths, we want to roll them over, look in the mouth, and see if there's anything in there that may have come out. Okay. If we see something, rake it out. Okay. Again, no blind finger sweeps in children and infant. Okay. All right, going into oxygen here, again, something to pay attention. This is a section you really want to pay attention to. You have, you have skills on this. This will be some of the things that we go over. If you have your skill sheets out there, or in front of you, it's oxygen administration by nominal breather mass is the skill. And again, not super difficult. It's but there's a lot of different variables there depending on which type of stuff that you have to use. We'll show you a couple different versions of some of these things. But again, every ambulance might have a little bit different, oxygen wrench, or a little bit different regulator, or, depending on the location you have. Like I said, if you end up rolling into the ER and helping out or something, you have several different types of oxygen administration scenarios that you could face there as well, just depending on the specialty nature of the patient or the facility. So just to kind of go over some of the basics here, oxygen is compressed to 2,000 psi and stored in portable cylinders. If you notice the picture, the bottle is green. Most all oxygen cylinders are going to be green or have at least some part of them green. All right. You may have some that are silver and green on the top. Excuse me. So that's kind of a universal sign for oxygen. As you can see, there's green in several different areas here on the regulator itself, on the tank, on the mask, and those are all just kind of indications that these things are for oxygen. All right. So the portable oxygen cylinders used by most EMS systems are either D or E sized, which is essentially, a fairly small, narrow bottle. Some of them are a little bit longer, and that differs from the big one that you see on the ambulance, which is where the oxygen port that's on the wall inside the ambulance, that's where that oxygen comes from, is a really big cylinder that's stuck in the side of the ambulance. So depending on the flow rate, each cylinder should last for at least 20 minutes. Again, it just depends on how full it is and how long they had to use it in the last call and all that sort of stuff. But nonetheless, it should be, if you're checking it, should be at least 500. It should have at least 500, PSI in there. So the pressure regulator or flow meter is what helps to regulate, like it says, to regulate the pressure. So it takes the high pressure in the bottle and reduces it down to a manageable flow rate. And that way we're not getting 2,000 PSI in our face all at one time, right? We just want it to like 15 or 20 liters per minute, So as you can see, there's a single unit attached to the outlet of the oxygen cylinder. So what we're looking at is where you see the little screw part on the left where their hand is, and all the way over there where the gauge and then the numbers are over here on the far right with the little port. Most oxygen regulators are similar to this. Again, you got different colors, some of them are different sizes, but generally they do the same thing. Some of them have a little bit better knob on the right that helps you to see the numbers. Some of them may have points on there, so like 5.5 or things like that. But generally they fit over the regulator the same way. They tighten down very similar, and they'll have a few different ports on there for you to hook different types of hoses into it. The other thing is, whenever we do this, we're adjusting it to liters per minute. Okay, so sometimes you'll hear that shortened on scene, and we're training and things. You'll hear it just say liters. So it'll come out like, yeah, I got a patient on a non-rebreather 15 liters, right? And that just means liters per minute. It's just slang, but it only goes up to about, usually most of them are going to go up to 25, and that's the max that we want to give. Typically, the only time you're going to give 25 is going to be with a bag valve mask. That's pretty much the standard flow rate for the bag valve mask. And then we may do, depending on the patient, you may go to somebody's house or somebody that's walking around with a portable oxygen, they're, like consistently, like every day of their life, and they may be on like 2 liters per minute. All right. Generally, the majority of the things that we use, like the big 3 are nasal cannulas, non-rebreathers, and non-rebreather mask, and the bag valve mask. And those range from 5, 15, and 25. That's the usual for that. Now, you get some patients who don't need very much oxygen, and the paramedic or somebody may tell you to regulate that down to a lower level for the mask. So the mask might be at 10 instead of 15. But there's also some that are just not capable of that high flow. They don't work correctly. So I think we're going to see it here in a little bit. But if you notice that stem that goes up and down on the bottle, image where that corkscrew goes into, there's a little green tab, and I'll show it to you when we get to the picture. But that little green gasket goes in there every time you get a new bottle. It comes with a new gasket. So whenever you're replacing this, always replace the gasket with the new. Always replace the new gasket with the old one, and make sure that you have it tightened down, well enough. It's a hand tight thing, but it's a pretty strong hand tight. So they make the oxygen wrench, which is what he's holding in his hand right here, and it it accomplishes several different things. The two little small holes on the end are for turning the actual tank on the top. And then the O2 wrench on the bottom is if you need to take the top of it off, which is very uncommon. Also, we use that circle in the back to loop it through that screw and tighten it down. So you can kind of use it like a little mechanical advantage and tighten it down. So nasal cannulas and face masks, again, like I said, these are the two big ones that you're going to see that we're going to use. The only other one would be a nebulizer, which is again basically the same type of mask, but it has a little plastic cylinder attached to it for if we need to put medicine in there for people with, say, asthma or emphysema or something like that, and we can put liquid medicine in there and vaporize it and get it to filter into their lungs. So it ensures the oxygen is delivered to the patient is not lost in the air. So again, those nasal cannula is the two little prongs that goes in the nose. I'm sure everybody's seen TV shows if you haven't seen it in real life, and it just sticks in either side of your either nostril and delivers the air that way. They again, medium concentrations of oxygen. It's not what we refer to as high flow. So it's just going to be a medium flow, a medium concentration. The face mask is placed over the patient's nose and mouth to deliver the oxygen. So it goes all the way over their face, has a little rubber band that keeps it in place behind their head. Non-rebreathing masks are most commonly used by EMR, EMS. They make what's called a simple face mask, which doesn't have the bag hanging down. We'll probably get to a picture of it in just a second, but the bag hanging down is the non-rebreather. Okay. So some safety considerations. Again, if you don't already know, oxygen is extremely flammable, especially in high concentrations like this. Okay. So very important to keep it away from sparks and ignition sources. Okay. So if we have somebody, we're definitely not letting people smoke around it. Patient can't, get one last smoke. You have these old people that are on oxygen who are on oxygen because they smoke too much, but they still smoke. And you go to them every 3 days and they're sitting there with their oxygen mask around their neck while they're smoking. Okay. So the concentration needs to be there for the big bang to happen, but nonetheless, it still could burn their face. You could have a quick ignition from a cigarette or some other type of spark or ignition source. So be very careful about that. So this is the gasket I was telling you about. You see the little green gasket here, and the two prongs that essentially pretty much all the regulators for these oxygen bottles are going to have a little section that pokes out, and it'll have two prongs. So the two prongs goes in those two holes, and the little male receiver will go into that hole, and and then you press that against that gasket and you tighten it down. All right. And the other side has a little indentation where the screw goes into, and that's how you tighten it down. And but this is key that you match these holes up correctly and you don't damage that gasket while you're doing it. That way we don't have any leaks or any issues later on with the air coming out. So again, we want to check the gauge on the pressure in the flow meter. Again, at least 500 liters per minute. 500 psi on the gauge. So whenever we turn the bottle on, so we take our wrench and we turn the bottle on, and all you have to do is like a quarter turn of that stem on the very top with the wrench. Turn it about a quarter turn. You should see the air increase on the gauge. The air will go to whatever pressure is in the bottle. That's going to tell us how much air we have to work with. Okay, so again, at least 500. And then from there, we are going to place our mask on our patient or our nasal cannula, and then we're going to set the desired flow. And and then we'll go from there. So it's again, whatever that liters per minute is, we'll set that and make sure that that's what they want, what's needed for that type of device, and then we'll proceed with with having them breathing it in or doing our bag valve mask thing, whatever we're doing. So that's a picture of the nasal cannula. Again, 1 to 6 liters per minute. About 44% oxygen, 24 to 44% oxygen, just depends on what you're doing there, what type of nasal cannula you have. But they are again a good supplemental oxygen source. A lot, like we talked about earlier, it just helps to take away some of the anxiousness, maybe reduce a little bit of their stress, and again help to oxygenate some, to some degree. If they're just a little bit below their oxygenation level that we want, the oxygen saturation level in their blood is a little low, and we just want to kind of bump it back up to get it into a normal range. Excuse me. So adjust that liter flow on the regulator to 1 to 6, and then apply the cannula to the patient. So the non-rebreather mask, as you can see, the telltale sign is it has the bag on there. So again, that is not a bag mask. That's what we manually do. This is a non-rebreather oxygen mask. Okay. So with this one, it uses 8 to 15 liters per minute, and it can deliver concentrations as high as 90%. Some of the issues that we have with this is that bag is you see the 2 little discs on either side of the nose cone. All right, that lets the air that you exhale, it lets it out, and then you're constantly breathing in the air in the bag, which is coming from the bottle. It just fills up the bag and goes straight in there. So that is so when we do that, when we turn on the air and we set our liters per minute on that mask, we want to put our thumb, our gloved thumb, our clean gloved thumb, over the top of the little valve, the one-way valve, inside there going to the bag. That lets the air fill up the bag. Once the bag is filled up, we let our thumb off, and we'll pull our string back, talk to our patient, make sure we understand we're about to put this over your face. It's going to be okay. Just breathe deep, that sort of thing. Reassure them. Put that over their face. Put the strap behind their head. Adjust it accordingly if it needs to be adjusted. And then we can also adjust our nose piece as well to make sure it fits appropriately and we're not losing any air. Of course, same thing. We're checking for leaks. Just like with anything, we have adult, child, and infant sizes. So make sure that you're using a proper size mask. Now for children, unfortunately, a lot of times they do not like the mask. So children and infants especially, you're going to have a hard time unless they're unconscious with them to keep the mask on. Sometimes with a little coaxing, they'll do it. They'll think it's cool or whatever. But usually when they're already scared, they're already hurt, sick, something like that, they are less apt to do that. So we have to use what we call blow-by oxygen, where we take a mask like this and we turn up the concentration and we sit it, like we just kind of hold it in their face and let the oxygen blow like under their nose, and then they'll just inadvertently breathe in that oxygen. They won't realize they're doing it, but it just takes a little bit. It just takes you having to sit there and hold it to do that. If you look around some of these medical magazines, catalogs and stuff for these places that sell medical equipment, you'll see that they have oxygen delivery devices that have a little, it's not a mask. It looks like it's essentially like a microphone with a teddy bear on the end of it, or, a dolphin or whatever. It has little holes in it. And so essentially they sit there especially for really small children, they sit there and they hold that, and it'll basically they think it's a toy, but it's actually oxygen or medicine, and it's blowing in their face, and they're breathing it the whole time. They just never realize it. So, you can make you a blow up glove doll or whatever, and make a face on it, write something on there, and make a funny little thing out of a glove with air in it, and and give it to them, let them play with it, and at the same time hold that in front of their face, and they'll probably be just fine. They'll breathe it in. So that's called blow-by oxygen for children. So again, we use this for shortness of breath, severe chest pain, carbon monoxide poison, any of these types of serious issues usually are going to get the bag valve. Going to get the non-rebreather mask. Again, we want to remain safe when we're doing that. It's just main thing with that is the explosion hazard. We just don't want to have that everywhere. So if you're not using your oxygen, turn it off and make sure it's secured. Make sure your valve or your regulator is secured onto your bottle all the time. So don't stand your bottle up. Make sure you lay it down because somebody will hit it, knock it over. And if you break the stem off that thing, it's probably going to go flying through a wall somewhere. So be very cautious about where you set it. Pulse oximetry, this is what we were talking about how to gauge whether or not how much oxygen saturation is in the blood. And this is how we do that. And it's called pulse oximetry. And this is a pulse oximeter. So the pulse oximeter consists of a sensor probe and a monitor that goes on the finger, any finger but the thumb. Usually the first or second finger there of each hand. We can, depending on what type of a pulse oximeter you have, it could also put it on your foot, but more consistently, it goes on one of the first or second fingers. So in a healthy patient, oxygen saturation should be between 95 and 100%. And that's kind of what we're looking for. It can't tell you what is wrong with the patient. Okay. It's not going to really give you a whole lot of diagnostic information. It's really just going to tell you what that oxygen saturation is and the pulse rate. And a lot of times it'll do that. That's pretty much the consistent, thing with that. The monitor that the ambulance has, it will do all that as well. So it's all connected. So they don't necessarily have their own individual one. Some places do. For a long time they did, but when they got new monitors, the monitor does everything. So it does blood pressure. It has a blood pressure cuff attached to it. It has a pulse oximeter attached to it and all sorts of stuff. So, it will, again, like I said, give you that recognition that, hey, this oxygen saturation is low, this heart rate is low, and that helps you determine whether or not you need to start treating the patient, differently, or if they need more oxygen or something like that. So a couple things here to remember. If the patient is wearing nail polish or has really dirty fingers, so greasy hands, stuff like that, if it's cold, lost a lot of blood, so you don't have a whole lot of systemic blood flow down to the fingers, or if they've experienced carbon monoxide poisoning, you're probably not going to get a good reading, or it's going to be a very low reading. And so if you can manage some of those things, that would be preferred. If you can try to clean off the nail polish or clean off the dirt, you try to warm the hand up, stuff like that, that might help you out. All right, so we mentioned stomas earlier. So basically, a hole in the trachea that allows a patient to breathe directly below the point of where most of that choking. Like we've been talking about choking in that upper airway section. So this would be below that, below the epiglottis. This goes almost just above the or not very far down before we get to the carina, or that location where the main branch happens, okay, in the lungs. And the stoma could be there because they've had surgery and had it done for some reason. They have some type of injury or illness that caused them to have a stoma that they live with every day. or it could be a stoma that is created from a surgical, we call a surgical cricothyroidotomy, which is what they would do, again, the helicopter, in the ER or something like that, to create a direct access into the lungs, bypassing the mouth and the throat and all that sort of stuff, or the trachea, the upper trachea. So again, if they have trauma in the face, trauma into the upper airway, then we really have to, we're not going to fool around with it. We're not going to waste a lot of time with it. We're going to go directly to ensuring that we save their life and keep them breathing. And that may be where we have to go directly into the trachea like that. Not we, but the advanced providers. So, but again, this is talking more about the ones that have already had it, and you just so happen to come upon a patient who has a stoma. It's going to be more of a cylindrical round hole. It may have some type of plastic device inserted in there, or that's wrapped around their neck that kind of stays in place. And it's it's a little off-putting. Sometimes it doesn't smell very good. You may need to clean it if of any type of debris or anything like that, any mucus that surrounds it. Again, these people may eat with it. They may, sometimes they'll take in other, medicines and do all sorts of stuff. And they can, there's a lot of stuff that comes in and out of there that we don't take for granted when we spit or swallow stuff and things like that. That comes up from our lungs that we just end up swallowing. It never reaches our mouth. So little things like that come out of that tube, or come out of that hole. So if there is a breathing tube in there, we want to remove that. So again, this is just for rescue breathing. Okay, so this is if that patient is unconscious and is not breathing, and we need to breathe for them, and they have a stoma, this is going to be our method to do that. So again, it'd be up to you if you want to put your mouth on that stoma. It's really not that difficult as far as the technique or whatever. You're just going to cover your mouth over the entire stoma. Okay. And we're going to ensure that chest rises and falls. So again, if it doesn't rise, we probably don't have a good seal, and we need to also make sure that we close their mouth and their nose to make sure that they are, that the air is not going up and out of their mouth or nose. So it sounds kind of weird, but it's almost like if you were trying to smuggle them, smother them. I'm sorry, putting your mouth over their hand, putting your hand over their mouth and their nose. Again, but like I said, we're dealing with that stoma, which is their direct route to their lungs. So we're not really worried about their mouth or their nose. It says a bag valve mask or pocket mask device can also be used to ventilate the patient. If they have some type of tube in there, that might be something where you can connect to it. That's the other thing that a lot of people will wear that because of that. They know they have some type of disease or chronic issue that's happened, and so that they may have the potential to need that. And so their little device that they wear over the stoma actually is the same size as a connector for the bag valve mask. But again, we would just nothing very different there. Like I said, it's just kind of off-putting. It's different. You don't really see it very often, but we're going to make sure we make a good seal out of that hole or whatever device that we use, and then we're going to ensure that we give enough air to make the chest rise. Okay, pretty simple. It's just like the other stuff. Not too much different there. So I mentioned gastric distension earlier. Essentially, if we don't do good airway management, then this is what happens. Okay. It happens often, usually even if you do it pretty well, you still may get a little bit of air intrusion down into the stomach. And that's what's happening here, is that we haven't done our head tilt chin lift well enough. And that air that we're pushing in there is not going in the trachea, and it's going in the esophagus and down to the stomach. Okay. that is, it's not, I mean, it's not good because the air is not getting in the lungs. So we're taking away from the patient. But the air in the stomach is not necessarily super detrimental to the stomach or anything like that. However, whatever's in the stomach is now being pressurized. Okay, so imagine if you took, a balloon and you filled it with whatever you had for lunch, okay, and put some stomach acid in there, and then you take the balloon, close off the end of it, and then all of a sudden you let the end of it go and you smash the balloon between your hands. All right. Yeah, that's what's going to happen if you pressurize the stomach enough, is it's going to come back up and out, and it's going to, I've seen it hit the ceiling in the ER before. No lie, swear to God. Okay, so that kind of stuff can happen. If nothing else, you're going to have a big belly that's really going to be really hard. Okay, and again, it's like blowing up a beach ball. Okay, so it's important for you to make sure that you're monitoring that as you're giving breaths. If the paramedics there and they're doing stuff and you're helping them out, they should be listening for that too whenever they do that. Also, whenever they do intubations where they put a tube down their throat, they will check and make sure that they don't have any air going into the stomach. They'll listen for that with the stethoscope and make sure that it's going into both lungs. Okay. So again, breathe slowly and having good airway management, opening that airway up completely, and not doing those breaths so fast will usually help prevent that. Dental appliances, again, there's tons of different things out there. 1, 2 teeth, whole sections of teeth, dams, and oh man, I mean, just all the different things you can think about for that maybe dental work, dental surgery, any of those types of things. Could be cotton balls, right? I mean, it could be gauze pads that are stuck down in an abscess or stuck down into a cavity space or something along those lines. So especially if somebody's on medication maybe and they're already lethargic and they're on pain medicine and they have all this crap in their mouth, then all of a sudden they start, and something happens, they roll over, they roll over, they start choking on something, that maybe the stuff breaks loose and they swallow it. I mean, there's a lot of different variables here, but I'm just giving you an example of some of the things that could happen or that have happened because of, dentures or dental implements that are in the mouth, and they could choke on those. So one of those things, just try to remove, if you can, try to remove those things as best you can. Obviously we want to try to interview anybody that might be around that might know what was going on with them or what happened with them. What could possibly be in there, and let's see if we can try to fish it out. So airway management in a vehicle, as you can see here, we really want to try to, it's not easy. Vehicle accidents in general, just depending on the type of incident, it's not easy to maintain spinal immobilization. It's not easy to maintain an open airway on a patient. However, for those of you who are on a fire department or something like that, or just gung-ho on the law enforcement side, if you have the right PPE, I'll preface it with that. If you have the right PPE on, if you're able to get inside there and just focus on patient care and do stuff like this, where you're holding the airway open, you're putting on a C-collar, cervical collar, like we talked about the other night, and holding their airway open like that, potentially putting in an airway adjunct, providing O2, that sort of thing while you're up in there. That is we have just increased patient survivability tenfold just by opening their airway and providing some oxygen, right? So the ambulance is not going to do that unless they can just reach the patient from a safe location outside the vehicle. They generally are not going to just go sit inside of a rolled over vehicle, crawl in there in the glass and everything and do that. They're just not. Okay. They're told that they don't have to. You know, I mean, it's just not in their, it's not in their procedure to do that. Okay. They are not extrication specialists. They do not have the equipment. They do not have the protective equipment to do that safely. They are not given that. They're not told to have that. That's not part of their kit that they bring to work every day. Okay. So for those of you, especially on the fire side, if you want to, if you're really concerned about that patient care, that may be something where, especially if you're in command or anything like that, dedicate somebody with medical training to get in there in the vehicle, as long as it's safe to do so, and start, do an assessment, open the airway, put it on a C-collar, things that we can do in that small space to help increase survivability. Okay. Again, this is just talking about doing it from the window, doing it from, outside the vehicle. And that's essentially the technique that you just saw, just stabilizing the patient's airway and their C-spine at the same time, just holding their neck in a neutral inline position. So, all right. So that's all the slides for tonight. Do you guys have any questions about anything that we covered tonight? I know there's a lot of specific information. We kind of dove a little bit farther back in, or a little bit farther down into the airway section there, and some of the anatomy, and we talked about a few of the some of the different actual medical problems that we may face. So, like I told you the other day, we're getting kind of into the weeds on the medical stuff. So, anybody have any questions about any of that sort of stuff? All right. I don't hear much from you guys. So, at any level. So I assume that you guys are kind of getting it. Okay. That's the only, other than your test scores and things like that. I can't really assess, where you're at. So again, if you're having an issue, if you're having a problem and you're not understanding something, please reach out and ask. Okay. Offline or what have you, personally give me a call, do whatever it is, and make sure that you're understanding everything we're talking about. Excuse me. So, again, like I mentioned before, if you haven't already, make sure you're getting in there on Canvas and doing your quizzes, and go back through your quiz, see what you missed, look at the page numbers on there, go back and research it. Okay. And make sure that you really understand the things that you missed. Next Tuesday, the 15th, is going to be CPR. We'll get that knocked out. Next Thursday. So next Thursday, we won't have class. All right. I'll put it out there on Facebook too. I'll remind everybody on Tuesday, but next Thursday is just an off day for you. Again, read through your books, make sure that you're ready for, make sure that you're reading ahead for chapter 9 after that, around that time. Chapter 9 is important. And that's one of the reasons, because I'm going to be out of town. So that's one of the reasons that I want to make sure that I go over it with you, is patient assessment. I mentioned this to you before. Patient assessments, both medical and trauma, are some of the most important things that we're going to do in this class. Okay. It's the way that we get the information that we need to treat our patients. All right. It's important. All right. You need to treat it that way. If you haven't already, you need to print out your skill sheets, your National Registry skill sheets, and that's going to have your medical and trauma patient assessment sheets on there. Make sure you have a copy of those. You're starting to memorize those and look at them. And as we go farther along in class, the things on those pages will start to make more sense. Okay. So that's about it. Like I said, make sure you're taking your quizzes, read through your chapters, and be ready for next Tuesday for BLS or CPR. And I'll give it one more shot. Anybody else got anything?
Justin.
Yeah.
How are we going to do the CPR and just on the computer deal?
Yeah, it's going to be part of your skills. So we're going to do the the didactic portion. So the same portion that you would do in the classroom, you're just sitting there watching the video. We're not going to watch the video, but we're going to go through all the same information that we do at the BLS level. So AED and all that sort of stuff, and which a lot of things we kind of cover tonight, realistically. But we're going to go on the go through that whole thing in the classroom, and then we'll finish it up whenever we get to do skills. So. Again, it's just broken up into segments. That's all. It's no different than anything else. We're just no different than anything else in the rest of the class. It's just going to be done at a different time. Anything else? All right, boys and girls, y'all have a good night. We'll see you next week.
Class number, Joe.
It's going to be R000. I believe we're at 5 now, right? I'm sorry, it's going to be 4. R0004. Everybody got that? All right. Appreciate it, y'all.